Well, welcome everyone to the second in a series of webinars from the Policy Lab here at the Center for Community Resilience on our national agenda promoting health and well-being across the lifespan. We are super excited to be here today, despite the fact that it's kickoff for our spring break for a lot of people. So we know a lot of folks are otherwise engaged, but this is being recorded. So you can share it with those who are actually maybe frolicking in the spring sunshine. But this is also the kickoff of National Public Health Week. And today's theme as part of National Public Health Week is community, which is not only a middle of our name here at the Center for Community Resilience, but it's also at the heart of what we do here. We work very tirelessly with community partners to not only understand the issues that are to be resolved, but also the partners that can come to the table to help co-create solutions. So I'm going to invite my panelists who are joining us today to come off camera so you can see their faces to talk about some of the very important issues that are at the heart of community here in the United States and really globally. But we are today going to focus on issues with regard to community health here in the United States. One of the first things that I want to kind of orient folks to who this is the first time that you've joined one of our webinars, your first time being exposed to the work that we do here at the Center for Community Resilience, is giving an idea of the depth and the breadth of the work that we do here. Today's webinar is being brought to you by our Policy Lab, where we work with community partners as well as other organizations. Two of our partners here that are joining us today to really focus on what are the issues and the opportunities to make systems change, whether that is big P policy or practice change within our organizations. And so this is the work, the translational work that we do at the Policy Lab. And today, many of these the very thoughtful discussions, as well as the presentation of data, will reflect many of the conversations that go on in community, but also with our partners as well as lawmakers, whether that's at a federal level, state, or local. Of course, everything that we do here at the Center for Community Resilience is focused, centered in equity. And so we have a host of tools as well as unique approaches to help community members lean into these very difficult conversations with regard to structural racism, but then also providing cogent, concrete, and tangible ways of not just repair, but also restructure in a meaningful way that helps to address trauma as well as healing and moving towards more productive outcomes for our children and our families. We do this through our national networks, the first of which was the Building Community Resilience Network, such as 6 community-based coalitions that are really working to get to the heart of the matter, what we call the pair bases. And if this is your first time coming to one of our webinars, I will certainly explain that to you in just a moment. But then also giving a role for local public health departments with our Resilience Catalyst and Public Health Initiative that puts local health departments at the center of creating these cross-sector, cross-disciplinary networks to address structural racism and long-term adversity. So this is what the networks looks like. As I said, 6 regional networks, 11 local health departments, and we're really pleased that all of those networks, plus a number of our key national partners, will be coming together in June of this year for our National Hill Day. It'll be the first time that we've been able to come together since COVID. And so many of the issues that you're going to hear today, we are going to be speaking directly to lawmakers with regard to issues of maternal mortality, as well as trauma-informed practice in schools, and really trauma-informed practice in the community. And we'll talk about that in a little bit. Also, but before we get to that, I want to get to some breaking news. Now, many of you may have heard a couple of weeks ago, it was announced that for the second year in a row, life expectancy here in the United States has declined. Now, we knew that this happened last year and largely attributable to COVID-19 that heaped on top of pre-existing inequities, not just health inequities, but social inequities. But while many of our peer partners across the globe seemed to rebound in 2021 or 2022, the United States did not. In fact, we continue to slide with regard to life expectancy, down to 76 years. So one would have to say, if it's not just COVID, what is going on? What is making America so sick? Well, when we look at the data, and we look particularly at public health science and public health data, we've known for some time what's killing us. It's not just health behaviors, whether it's poor diet, sedentary lifestyles, or higher disease rates, or even substance abuse, but it's also what's in the soil feeding these negative outcomes. For the first time, we've seen child mortality rise at the hands of or attributable to injury by firearm, child poverty, racial segregation, social isolation, and just as we saw just this past week, Nashville, Tennessee, with regard to gun violence. Americans are dying younger because America right now is bad for our health. And so this really creates an even more urgency around the national agenda. It's not just one issue. It's looking at those essential building blocks so that we can begin to address these systemic inequities, those things that we know are not only bad for our communities, but they're literally killing us writ large. So that's why when we talk about this work, we don't just look at what's on the branches and the leaves. Trauma, adverse childhood experiences as they are described, or these experiences as they're described, not just the traditional 10 ACEs, but also including poverty, hunger, and housing stability, natural disasters, and or terrorism. And we can include these mass shooting incidents as domestic terrorism, as domestic community trauma. Refugee or war experiences, these things, understanding and enduring the experience of racism, systemic inequity. These are on the branches and the leaves, but they're also fed by what's in our soil. Discrimination, community disruption, the lack of opportunity, economic mobility, and social capital. Here in Washington, D.C., 1/4 of our children live in poverty. Our maternal mortality level is 2 times the national average. And we're looking at a population here that has a huge income disparity. One of the highest paid workforces here in the United States. And yet we still have a high rate of Black maternal mortality, even amongst those women who are highly educated, because we know that education and income do not completely buffer against the long-term experience of racism. The racial wealth gap here in Washington, D.C., just as it is across the country, is astounding, is crippling. Unaffordable housing is feeding a large part of that. And D.C. is not unique. This is the American story that roots many of our traumas, our initial traumas in community, back to systemic racism. So in keeping with the theme today for National Public Health Week, we want to recall and remember community context matters. And so this is what the thinking that goes behind the 9 building blocks of community resilience for the Center for Community Resilience, as well as for our many partners: child health, maternal health, education, child care, workplace policy, foster care, health care, child nutrition, and reproductive justice. And so today, I'm very pleased to be able to share with you some work from our partners and important reports from our partners around Black maternal mortality and schools as community hubs, because this isn't just a webinar about the problems. This is also a webinar that helps us see the good work that is going on and lifts up these models as national possibilities, national opportunities for change. And so it is with my great pleasure to introduce today's speakers. We'll start with Veena Smith Ramakrishnan, who is a senior policy associate at the Century Foundation, where she works on issues related to maternal health and reproductive rights and justice. Veena's work supports the Century Foundation's efforts to eliminate racial and gender disparities in health outcomes. Aza Nedhari is a mother, wife, graduate student, and also executive director of Mamatoto Village. She currently resides in Washington, D.C. with her husband and 3 amazing children. At Mamatoto Village, it is devoted to serving Black women through the creation of career pathways to maternal health and providing accessible perinatal support services designed to equip women with the necessary tools to make the most informed decisions in their maternity care, parenting, and lives. In fact, their vision is a vision that we share here at the Center for Community Center for Community Resilience. And that is a vision for healthy mamas, healthy babies, and healthy communities. Community and dealing with community trauma is at the center of the work for Jessie Kohler from the the Campaign for Trauma-Informed Policy and Practice. Jessie's going to talk to us about a recent report from CTIPP on schools as community hubs, the opportunity for change that's right in front of us. As executive director of CTIPP, Jessie is in charge of organizational administration, fundraising, strategic planning, public engagements, and working alongside staff, and I might add also legislative staff, the important outreach work that we must do to inform policy and practice change. So with that introduction, I want to turn this over first to our colleagues at the Century Foundation to give us a legislative update.
Hi, everyone. Thanks so much, Wendy, for that introduction. I am going to share my slides now. Great. Can you see okay? Wonderful. Well, hi, everyone. Happy Monday and happy start to National Public Health Week. I'm Veena, as was mentioned. I'm at the Century Foundation, where I'm a senior policy associate, and I'll be chatting with you all today about the Black Maternal Health Federal Policy Collective and some of the legislative work that we're engaged in. So just to kick things off, the Century Foundation, or TCF, is a progressive independent think tank. We're conducting research, developing solutions, and driving policy change to make people's lives better. And we do all this work through an equity lens. As I mentioned, I'll be talking a bit about the Federal Policy Collective, as well as kind of just laying the groundwork for the U.S. maternal health crisis. And I'll briefly touch on the Momnibus, which is one of the legislative pieces that we've worked on as a collective, before I pass it over to my colleague from the collective, Aza, to discuss a little bit about her work at Mamatoto Village. So just a brief overview. I know Wendy touched on this a bit already, but in the US, our maternal mortality rate is far outstripping that of other industrialized nations. We are leading the way, and not in a good way, when it comes to maternal mortality. And when we break that data down by racial lines, it's even more concerning. We have recent data that just came out from the CDC recently, showing that in 2021, Black women and birthing people are going to be over 2.5 times more likely than their white counterparts to die from pregnancy-related causes. And we know the COVID-19 pandemic has had really stark impacts on what was already a dire maternal health crisis in this country. And we want to emphasize that racism is really the driver of these poor maternal health outcomes. Cumulative stress of racism and gender oppression is really undermining the well-being of Black women and birthing people in this country. And the white power structures that exist in our current healthcare system, with lack of empathy and respect for Black women and birthing people specifically, as well as other women and people of color, are really driving this crisis. And so when we think about solutions in the policy space, they need to be grounded in social justice frameworks like the reproductive justice framework that we'll be talking about in a little bit. So now enter the Black Maternal Health Federal Policy Collective. This is a group that was founded by then TCF Director of Healthcare Reform, now President and CEO of the National WIC Association, my colleague, friend, and old boss, Dr. Jamila Taylor, who brought together a really dynamic group of Black women leaders from across the policy sector to develop strategies and solutions to tackle the American maternal health crisis. And the collective currently is a go-to for policymakers, advocates, the press, and the public. We produce a number of different documents on things like the intersection between abortion access and Black maternal health. We convene congressional briefings to educate policymakers on these issues and why Black women and birthing people really need to be centered as we're developing policy solutions for these issues. And I'll just do a quick brief overview of the Momnibus, which is, really a policy solutions to this crisis that were centered in community. Back in 2021, lead co-sponsors, Representatives Lauren Underwood and Alma Adams, and then in the Senate, we have Senator Cory Booker, who are leading the way to address this complex crisis. The solutions to the crisis need to be comprehensive because we know that the crisis is comprehensive. And so the Momnibus was a suite of 12 different bills, each of them focusing on different issues ranging from climate change to maternal health vaccinations, dealing with COVID-19, as well as social determinants of health. And something special about the Momnibus was that it was really crafted in community with these relevant stakeholders, everyone from birth workers like doulas and midwives to community-based organizations to other advocates, really with the intention of centering the lived experiences and the lives of Black women and birthing people. And just to provide an example of one of the parts of this legislation that I think really speaks to that is the Kira Johnson Act, which had community-based organizations serving women and birthing people of color, who are already really doing the work, and we're going to hear from Oz about that in a bit, to address these disparities, but they lack sufficient funding. And so this bill within the Momnibus would establish grants to be awarded by HHS with a focus on investing in community-based organizations. In 2022, last year, we unfortunately did not see the maternal health investments from the Momnibus included in the Inflation Reduction Act. But one policy win from last year that we did see was that Congress passed permanent extension of Medicaid coverage to 1 year postpartum. And more than 30 states so far have elected to take up this option. TCF was tracking the progress of the Momnibus in last Congress, and we'll stay tuned that this year when the second iteration is going to be introduced in Congress, we're going to continue tracking progress of those new bills as well. So what's coming next? As comprehensive as the Momnibus is, there is still a lot more to do. And so legislators and advocates are currently in the planning stages for the next iteration of legislation for the Black maternal health crisis. And that is going to be Momnibus 2.0, as we're calling it right now. So this next suite of bills is going to address not only maternal mortality, but also maternal morbidity. And we're really excited to see what's going to come next. And with that, I'm going to wrap so that we can pass it over to my colleague, Aza.
Before you toss over to Aza, I do want to reiterate, and really stress to those who are with us today, is that, while the Momnibus has this, real focus and necessary focus on Black mothers, we know from a policy perspective that using targeted universalism, such as this type of policy, has the opportunity to benefit all birthing people. And knowing that those that are at the greatest risk, if we can improve outcomes for them, we will have this ripple effect across maternal health for all. And so I just really want to thank Vina, your work that you're doing there at the Century Foundation, as well as others, to remember that while, yes, equity is absolutely important, and this is absolutely what's needed for Black mothers, that this has the opportunity to really have great impact for all of our outcomes for birthing people. And so with that, I want to turn it over to Aza.
Thank you. And thank you for giving me some space and time to share a bit about the work of Mamatoto Village. So we are celebrating 10 years this year of providing radical collective care in the DC area, 10 years of working hard towards healthy mamas, healthy babies, and healthy communities, and being in partnership with Vina and some of you who are on this call today. So as introduced, Mamatoto Village, we are a DC-based Black-led organization here in Ward 7. Mamatoto is this rich space of culture and innovation and collective care and responsibility. And our work is really anchored and centered in providing both comprehensive perinatal support as well as workforce development training that really seeks to bridge gaps in communities in both the district and PG County. Our work is reproductive justice and birth justice centered, meaning that we support birthing people in their right to have children, their right to not have children, and the right to parent children in communities in safety and dignity. So as Vina said, just to really contextualize Mamatoto's work and really why there's a need for community-based services that are culturally resonant, that do center the needs of Black women and birthing people, is looking at our current maternal mortality rate. And so in 2021, there were over 1,000 mothers who died during childbirth. And of that number, 356 of those mothers were Black. In the district, we know that the majority of maternal deaths are really centered in Ward 7 and 8. And most of the mothers that we lose in DC are mothers who are Black. When we look at this data and kind of go deeper into it, we look at the impact that COVID had on a disproportionate impact on Black people, and that the majority of these deaths that we are looking at were exacerbated by COVID. We know that COVID shined a light on social determinants, on access to care, on the interplay of living environment, employment, on maternal and infant health disparities. And so the work that Mamatoto does in perinatal health care and workforce development is really centered in this model of wrapping around the entire family, a model of 3 generations where we don't just look at the mother-baby dyad, but we understand health and well-being as something that is transmissible across multiple generations, and that it is an upstream solution if we are to lift the entire family and community towards a model of wellness. So our domains of impact really center along 3 areas: our perinatal home visiting, workforce development training, and policy and advocacy. So our home visiting program is a homegrown model that provides birthing people with expansive ancillary support services during pregnancy and postpartum. Our families receive health education, support with social navigation needs, care coordination, labor support, lactation, mental health, you name it, we provide it. Those services that we cannot provide, we partner with other community organizations who are better equipped to deliver those services. We do offer our care in a team-based approach in order to have a protective factor against burnout, which is common in a home visiting population. We do pay equitable wages at Mamatoto because for us, it's important not to model the same systems that we are trying to work against, right? And so we pay exceeding the DC average, the DMV average, as well as the national average for compensation of home visitors, as well as community health workers. We've served over 2,500 birthing people and families in this program. 100% of our families are on Medicaid, and we have maintained a 0% maternal mortality rate. Our workforce development training prepares Black women and people who are interested in entering maternal and child health and human self careers, giving them a stepping stone into that. It is important for us that the workforce looks like the community that is being served, and that we are moving away from models where we are transplanting people into communities without having a deep connection there and a deep understanding of those communities that are being cared for. This training is unique in that we do use a community health worker blueprint, but lend us a perinatal specialty in that focus. And then we infuse that with an understanding of all the centers of justice and how they impact Black people's lived experience, as well as their experience navigating healthcare in this country. And lastly, our policy and advocacy initiatives. And so the Black Maternal Federal Policy Group is just one of the areas in which we are intersecting both at a local, state, and national level, understanding that policy really does require, especially in this country, a reckoning with this legacy of medical racism and its symbiosis with the manifestations of multiple intersections of justice. And so we want to be, as an organization, a conduit to the resources that amplify the voices of Black women and their families to be witnessed, to be funded, to be elevated as subject matter experts. So lastly, just leaving you all with kind of a call to action. One of the pieces I know of this conversation is mental health. And I think that's the next speaker's conversation. But as I set him up, understanding mental health and to understand the infant's mental health and children's mental health, we need to understand the mental health of the parent. We cannot begin to discuss one without the other. And we know that the mental health of mothers and of birthing people during pregnancy and postpartum are often prevalent and clinically under-recognized. We understand that the mental health of birthing people and of mothers can disrupt fetal brain development when their mental health is not optimal. And we also understand that fetal brain oxygenation and functional connectivity, so the ways in which those neurons are connected and functioning, are impacted by the mental health of mothers and of birthing people. And if we were to view, perinatal health from a more expansive place, we would be inclusive of the non-birthing parent and of partners in understanding the well-being of mothers as well. And so, I'm asking you to get informed, to increase your knowledge and awareness about Black maternal health and reproductive rights issues, to really understand the needs of children and of family and of community, to ensure that all families have adequate and culturally reflexive access to mental health resources, as well as their social needs being met, and then expand educational opportunities and academic programs to really support the introduction of clinicians into this space, again, so that this field is reflexive of the diverse experiences of all birthing people in this country. Thank you.
Well, Azza, that is so powerful. I want to take a moment, though, to ask you a clarifying question, because what is at the center of what you're trying to address with Mamatoto has been some of the processes, not just within the healthcare system, but writ large, that has created these stressors, inordinate stressors on Black birthing people. One of those things is when we talk about, and I think you hinted to this with regard to this focus on, or trying to not only have the focus on the mother-child dyad, but recognizing this community that this mother is going to be joining and that this child is going to be joining. And so my question to you is, what is the inclusion, the philosophy around inclusion of fathers? Because we know that many of the maternal child health programs have been designed to the exclusion, and particularly of Black fathers. And so how does that, how do you address that within the work that you're doing at Mamatoto?
Absolutely. And I do want to take it back, because again, I think everything has to always be contextualized in our history. In the history of this country, when we look at the longstanding impacts of enslavement, there was institutional and systemic removal of the father, right? And then there was this dynamic where it was encouraged, right? So in order to get social benefits in this country, right, oftentimes people have to not name who the father is. You have to not include the father. When we think about how fathers are included in the navigation of perinatal health, oftentimes all the materials are exclusionary of fathers. They are treated as a fixture or as a side piece, right? Or as an afterthought. Even when we're talking about mental health and we're looking at the impact of maternal mortality and morbidity on families, fathers are excluded. The impact of that on the entire family is often excluded from this conversation. And so for us, we believe that if we want fathers to be involved, we have to include them from the beginning. We can't ask them to show up on the back end or say, well, why didn't they show up? I'm like, why didn't we include them? Why didn't we give them a voice? Why didn't we give them space to process their fears and their concerns and their realities? Because they too are having an experience of pregnancy. And it's not the same as the birthing person's experience, right? Often the father is having this outward experience, right? They're just like, I don't know what's happening. I'm here. I don't understand what's going on, but I'm trying to be as present as I can. Our policies don't support fathers, right? When we think about parental leave, that is almost non-existent. Oftentimes families who the father wants to stay home and they want to bond with the baby, they have either no leave or they have extremely limited parental leave, maybe a week at best. And so I think that our entire system has to reorganize itself around this idea of family, that family is not just the mother and the child, right? That maternal health is not just that. And I think even reframing our language to think about family health or perinatal health, which can be more comprehensive and more expansive and inclusive of the realities of all the people who are involved in the experience of that child's life. So we do include fathers. We include non-birthing parents that may not identify as a father or as a male. And so it is important for them to be there every step of the way, providing information, providing affirmation, and providing that safe space for them to be confident in the role that they are also stepping into.
Oh, thank you so much. That is the perfect answer. But I really hope that those who are out there, I know there's some of my students are actually who are on the maternal child health track. We're trying to start this little not so quiet revolution, and that is, let's get rid of this idea that it's maternal child health. And it really is community child or family child health. It has to be, we have to think about context. So thank you so much for that answer. And please, I encourage any of those of you, we will have time for Q&A. Please put your questions in the Q&A and we will get to those. But, on this note, transitioning to you, Jessie, we have talked about community here, and I love what Azza said with regard to health and well-being, transmissible across generations. And we know that the science actually indicates and helps us understand how stress and trauma is transmitted through generations. It literally gets under the skin. But in keeping with today's theme around community, we see schools as this great opportunity, as this hub to work across generations, but also, as this hub for community health. And so I'm really, thank you again, Jessie, for joining us today to share with us some of this latest information from the Campaign for Trauma-Informed Policy and Practice.
No, thank you, Wendy. Thank you, Veena and Azza as well. Incredible presentations. And like you just said, Wendy, I think that schools are so important because there is a place where virtually every child and family is engaged in a support system that we can develop healthy relationships that help to buffer against stress and adversity. And we've seen trauma-informed schools be that solution. I just want to start with a quick personal story. At CTIPP, we use Marshall Ganz's framework of the story of self, story of us, story of now. And so that's how I will structure my presentation today as well. But during my own educational experience, my childhood best friend between 9th and 10th grade when we were 15 passed away. And when I came back to my sophomore year of high school, I was constantly reminded of him in school because that's where we had spent our entire lives to that point. And rather than being met with compassion about this event that really shook the whole community, I felt like I was met with judgment instead, and I was diagnosed and labeled with what was wrong with me, rather than an understanding and appreciation of the grieving process that I was going through. I was so fortunate to have a supportive family and friends, as well as some staff and coaches that helped me feel less isolated. And I need to highlight that extracurricular activities were such a healing opportunity for me through that process. But after Oberlin, when I first started my professional experience, I had a fellowship with a nonprofit in Philadelphia called 12 Plus. And I was in a Philadelphia public high school working to promote post-secondary pathways alongside students. The organization itself needed to exist because the student to counselor ratio in the city at the time was 600 to 1. There just was not the capacity within schools to support students the way that they needed. And I was struck by how much more adversity so many of the students that I worked with faced with far fewer supports. So many of the students experienced poverty and racism and community violence. I worked with multiple students that lost multiple friends that year to gun violence. And I recognized that we needed to create conditions of empowerment and safety so that they could reach their full potential. There was so much potential in the schools, and the systems and structures just were not organized to be able to help students reach their full potentials. So I saw the promise to create a stronger and more engaged country through education reform, and recognized that the system itself perpetuated inequity. And one example of this is that a large proportion of education budgets rely on local taxes and so in lower income communities. And historically, that is impacted by redlining and other policy decisions. We see how that can perpetuate the cycles of poverty and opportunity that many of these students and families had. And the need, especially in those underfunded schools, to compete for better test scores oftentimes led to more punitive environments themselves. As I learned more, I saw the promise of trauma-informed schools, which gets us to the report that CTIPP launched last year. And then I will get into some of the policy opportunities that have come about. So in trauma-informed schools, we need to recognize that how the brain operates, the human mind, body, and spirit under stress and adversity cannot easily perform the complex and long-term thinking that is necessary for academic success. Trauma itself can make it difficult to follow the rules and focus on assignments in school. And we know that these environments that provide compassion and support for those who have experienced trauma are so necessary. As you'll see on the right there, a famous quote from Dr. Bruce Perry is that as social creatures, the greatest buffer we have to address and prevent trauma is supportive and healthy relationships. Trauma-informed environments and out-of-school time programming are so necessary to help children and families cope with trauma that they are experiencing. And so we continue to advocate for supportive school environments to improve lives and support society broadly. We know that this is not just some students in schools. Some reports tell us that as many as 2/3 of children have reported at least one traumatic event by age 16. And coming out of the COVID-19 crisis, we know that there has been overwhelming stress and chronic adversity that has disproportionately impacted marginalized communities, as has been shared on the webinar so far today. And Wendy did a brilliant job of outlining the various potential traumas that can be experienced. And we know that school bullying is also involved in that. And so we need to provide environments that are able to support whatever a student comes into school with, as well as staff, and create universal precautions so that all students can reach their full potential. Trauma can show up in the classroom in any number of ways. And though there's three images here, I think about it even more simply as, you can see trauma as hypervigilance, and you can also see trauma as dissociation. So we can't just automatically know how trauma is going to show up, but we need to recognize that a lot of times students who are acting out may be experiencing trauma, and punishing them further, creating and strengthening that eject-reject model that our education system bolsters, can further push them away and lead toward further isolation when what they need is really relationships and supports. And also those students who may be dissociative in the back of the classroom, not really speaking, they may be experiencing trauma, and we need to have systems that reach out and create healthy relationships with those schools. So what we're talking about when we talk about trauma-informed schools is a whole community environment, not just a counselor who is trained, because again, that is just abjecting the strong relationships that students have the opportunity to develop with their teachers and the staff that they deal with every day, but creating an understanding of trauma and stress and adversity across the school environment, and recognizing how students and staff and other community members can compassionately interact with one another. And we know that it is a commitment to an ongoing process that is individualized for each school community. The trauma-informed environments depend on the needs, the resources, the populations, and the desires of each school community. So it's not a one-size-fits-all model. But we know that some of the common elements for transformation that we see are psychological safety is prioritized and modeled from the top. Administration needs to take a leadership and be involved in the process. There's training to better understand trauma-informed care and science, as well as how to support regulation skills and the importance of parallel processing for the staff themselves as well. We know that a dysregulated adult cannot help to support a dysregulated student. We need to have that co-regulation going on. There's ongoing conversations, and relationship development and maintenance are prioritized. Behavior, like I said earlier, is viewed as an adaptive way of communicating unmet needs, especially for children. And there are appropriate measures taken to repair harm, and punishment without opportunity for restoration is avoided. So restorative justice practices are really prioritized. In our report, we highlight 2 schools in particular that saw tremendous outcomes. And again, their transformation, their processes are different, but the results at John T. White Elementary is that suspensions dropped by 98% in 2 years, and the school passed the state exams for the first time in its history. Teacher retention also increased, and there was just a calmer overall culture that was reported. And we also know that in Hawaii, we saw very similar outcomes where graduation rates increased, early college enrollment increased, and teacher vacancies reduced over the 5-year period of their project. And this particular project was based in native Hawaiian practices, so it looked different than what it did in Texas. But as we have conversations emerging from COVID about how education needs to restructure to make up what people are calling learning loss, the trauma-informed school movement is helping to address the underlying causes of what is leading to less academic retention, lower graduation rates, teacher turnover as well, and really helping to raise all of those sustainably moving forward. We're talking here today about whole community environments, and so I wanted to highlight the community schools model. And this is a direct quote from the Learning Policy Institute. But community school strategy transforms a school into a place where educators, local community members, families, and students work together to strengthen conditions for student learning and healthy development. As partners, they organize in and out of school resources, supports, and opportunities so that young people thrive. This resource is intended to unpack the essentials of community school transformation and show the activities community schools undertake as they move from their initial commitment to the strategy of full implementation. And we see how the strategy revolves around a continuous improvement cycle that includes planning, implementing, working toward impact and outcomes, and monitoring progress, all of which rely on a supportive infrastructure. And community schools have been a proven model, an effective model that continue to expand to include full community members and voice from students, staff, parents, and other key community stakeholders in the process of how we are creating full communities of supports and recognizing the important role that schools play in communities and in children's lives. And there's another movement toward democratic schools. At CTIPP, we talk about democracy as the antidote to trauma, the regulation skills, the ability to sit down at a table with folks who we may disagree with and listen and think critically are all skills that are needed to both regulate when we feel dysregulated from potential traumas, but also are necessary for the democratic process. And as we move forward, we need to engage students and parents and staff voice in the ongoing process of how we are creating democratic schools, which we know as we uplift voice, we know that we are creating more trauma-informed environments. And so I just want to end with highlighting a few of the legislative opportunities that have come out of the report and 2 others about cross-sector collaboration that we are also pushing for. So last year with the report, there is money in the Bipartisan Safer Communities Act that can go towards supporting trauma-informed school environments. We did a webinar with the Department of Education trying to talk to state departments of education because the funding can be leveraged for anything that is perceived as community violence intervention. And so while it can go toward trauma-informed schools, it could also go towards, say, metal detectors in schools. And so there now needs to be a grassroots push towards state departments of education and at the local level to leverage these funds that are available to push toward trauma-informed schools to address the root causes of violence and create healthier communities as a whole. And last but not least, there are two bills that are in Congress, the Rise from Trauma Act and the Community Mental Wellness and Resilience Act, that support cross-sector coalition development. The Rise from Trauma Act establishes and expands various programs to support infants, children, youth, and families who have experienced or may experience trauma. And specifically, the bill allows for federal agencies to use specified discretionary funds to implement pilot projects to improve outcomes for children. And the Community Mental Wellness and Resilience Act awards competitive grants from the CDC to consortia that represent various community entities like schools, businesses, and health and human service providers for carrying out community mental wellness and resilience programs that use a public health approach. And so we need to take a public health approach, recognize how trauma at a systems level perpetuates stress and adversity disproportionately on marginalized communities that then create negative outcomes at the individual, family, and community level, and take a systemic approach, recognizing how marginalized communities are disproportionately impacted, and create cross-sector coalitions that then help us to start to rebuild the systems and structures that perpetuate stress and adversity and trauma and allow for us to get toward promoting healing and resilience. So with that, Wendy, I turn it over to you. Thank you so much for the opportunity to be here with you today.
Yeah, absolutely, Jesse. And thank you for that legislative update. I do want to remind everyone that while Jesse's presenting and, the big P policy piece was just absolutely important in this work, there are already levers in place to do this work in community. It's not just, just as, Vina has also presented, legislative opportunities. Aza was giving us concrete opportunities of work that is going on in community that didn't wait for federal legislation, but actually creatively draws down from existing funding streams, as well as creating public-private partnerships. One of the things that I want to bring to folks' attention is, Jesse, you talked about some of the benefits of these trauma-informed schools, and you spoke to, reading comprehension being what those things at the student level, reading comprehension being increased, as well as kindergarten readiness. We've seen this long-term from the Head Start programs. We have also seen some of the drop-off from the gains that we get from these kids that are in Head Start because we're not supporting them, as they matriculate through elementary school, which is actually making the case that we have to have these reforms throughout the matriculation of these students' lifespans. But one of the things that didn't come up when you stated the teacher retention, but I think it's important for people to know why we see increased teacher retention and less burnout from teachers. This is actually where your two topics intersect, because we know from trauma-informed schools that it's not just the practice of caring for our students, but you can't, care for students if you haven't cared for yourself, if you haven't recognized your own traumas, and you're in an environment that actually allows for you to express that and to be supported. And that's exactly the same thing that Aza's doing with Mamatotos. It's not just we're here to help you birth this child, but we see you as as a whole human being becoming a mother. We see you as a student becoming a teenager, becoming a part of your community. And so actually, I want for both of you all three of you to really pose that question. What does it look like when we actually holistically own community trauma and not just one person at a time. So perhaps, what would owning community trauma from a school perspective look like? But what does that look like also in practice as you not only help individuals, go through the birthing and parenting process, but you're also dealing with a lot of issues that are coming out as they're beginning this whole new phase of life.
Yeah, I think it starts with one, always an acknowledgement that something has happened, right? You can't even begin to addressing the thing if there's not an acknowledgement that something has happened, and that the thing that has not happened is not inherent to the individual, right? And so that you're not putting that and saying, what's wrong with you, right? Why are you showing up like this? You're asking what happened to you. You're asking, how can I care for you? What do you need? How can we be a support and a resource for you? And we're not asking from a paternalistic or maternalistic place, right? We're asking to be partners with the person that we are caring for, and giving them the space and sometimes name to what they've experienced, right? And sometimes when we talk, when we train our staff on trauma, one of the things that we talk about is the difference between trauma that is widely recognized, right? And trauma that people deal with personally that is often invisible. And then there's this public acknowledgement and acceptance of your trauma. And when that happens, right, usually you get lots of support, right? So we look at the difference between a group of people who have experienced a collective trauma that in some ways society feel is validated, right? So there was like a recent tornado, I think out in the Midwest, and everybody's seen that on the news, and we would all acknowledge, right, that those people went through something traumatic, and people will give donations and resources to support these people. Then you have somebody who was a victim or survivor of abuse, right, domestic abuse or sexual assault. And sometimes those things happen in private, right? And in many ways, sometimes their experiences are not validated, right, by society. And so it makes it much harder for those individuals to get the resources that they need, the supports they need, the healing that they need to begin those journeys. And so what we do at Mamatoto, and what I think is required when we talk about this ownership, because it is individuals who make up community. And so I think that it has to be a both and. There has to be an individual acknowledgement of what people have experienced and have gone through and are currently gone through, while also having community resources and safety nets that are in place to hold those things. There also has to be training for the people who are doing the holding, right? That we can't just show up and be like, I just want to help. I'm like, yes, we can do that, right? Hearts to serve are important, but we also have to be intentional about how we show up to care and ensuring that we're not transferring our own traumas, right, onto the people who we are caring for. And I think lastly, and then I'm going to bump it over to Jesse, is really thinking about the thread that we weave through community of care. That I think that we often in this country, we do so much siloing that we lose the impact of the people who are needing the most support. And I also think that we do so much of everybody needs all the things that the people who need the most amount of support often get lost in that. And so I do think that we have to weave these experiences. Like there's, all of the experience of becoming a parent, the experience of being a child and growing into adolescence, and then you one day maybe or maybe not becoming a parent or auntie or some other role where you are now on the other end of being in the life of a child. It's all one circle, right? And I think that when we start to look at it that way, that there is this aspect of a collection, that there's this village, that there's this journey that we all will go through, this cycle that we call life. I think that when we can start to approach and align our policies and programs to that understanding, that the thread won't drop right along the way, that we will weave the experience that in becoming a parent, you need support. When your children are going into school, the school should also be a resource for the child as well as for the family. I think that I look at LeBron James's school model, right? And I'm always like, why aren't we doing more of that, right? Why aren't we thinking about that families may need food, they may need a place to wash their clothes, that families may need support with finding employment, or they themselves may not have had the best educational experiences. So how do we give them a stepping stone so that now they feel empowered to be more involved in the life of their children? Jesse brought up an amazing point that dysregulated adults cannot then show up and parent in a way that they want to parent on their own terms, that they may struggle with those tools to be able to utilize to support their children. And so how do we do that from a way that does not criminalize and demonize families, but that lifts them up so that the entire community is then lifted up?
Such a beautiful vision there, Jesse.
Aza, it's very intimidating to follow you, and to do it twice in a single webinar is very difficult. I appreciate everything that you said, and just want to uplift all of it. I think that, you know, at a systems level, we need to recognize how the factory model of education that pushed through has reinforced so many negative aspects of the education system, both for students and staff, where teachers oftentimes get into the role of teaching. Like when you talk about teacher burnout, I know that when I was in the education system, I saw how, you know, teachers got into that role to really want to address and help and support students, but then the need to teach to the test and just work through incredible lesson plans really took away that opportunity for relationship building. But then also for the students, that there's a lack of inspiration that goes into just sort of burning and churning through education, instead of doing a lead from behind model of education that lets students explore their interests. So oftentimes it's confined and refined to very specific topics, and there needs to be a balance there. And then, like I talked about at a systems level, we really need to reckon with the ways that opportunities are not equitable across the country, the way that local taxes impact the education system and then perpetuate underfunded schools that then create its own slew of problems that lead to punitive environments that then reinforce the school to prison pipeline and that eject reject model of education that then permeates throughout our society, just continues to not create the productive and strong workforce society citizenry that we need to become a stronger country. I mean, going back, Wendy, to the figures that you showed at the beginning of this webinar, where, you know, the United States is really struggling, and the systems and structures that we currently have are just not adequate or sufficient to meet the needs that we have. And we want a healthier and more productive citizenry and populace across the country. And currently the education system, I think that if we want to take that, like, how do we really address the community trauma? We need to engage everyone's voice to really discuss the realities of what it's like in community right now, and then bring folks together with skills to be able to sit down and dive into the really wicked and complex problems that we're dealing with to help come up with innovative solutions. And that's going to look different from community to community. And we need to create conditions of empowerment and safety for members across communities to share their honest feedback, to begin to address those really sticky problems and come up with really innovative solutions that we can continue to learn from. And I think that that's the most exciting part of this work, is when, you know, you start to see that innovation and the success, and that builds off of itself and creates hope that helps people keep moving forward. We just need more of that.
Yeah. I want to thank you, Jesse, for that, you know, nod to our model for our framework around community resilience. You know, there's no denying the connection between housing, public education, criminal justice, and law enforcement. The literature demonstrates that these are the systems that are most proximal to influencing the community outcomes that we see, whether that's maternal mortality, whether that's child or infant mortality, whether that's educational attainment. How we fund our schools is fundamentally based upon the property values in that particular neighborhood. How we police that neighborhood is also differential by the housing income, by the property values, and certainly by the proportion of individuals of color. These are all intertwined. And so, yes, these are huge systemic issues, while at the same time, there are things that we can do on the ground. I really want to applaud, Vina, the policy work that you're doing, as well as Jesse and Aza, giving us practical examples of what we can do. One of the things that I do want to point out is that we've talked about schools as community hubs. And, Jesse, you've spoke quite eloquently about what that looks like. We have a partner, and I think she's still on the line with us, Caitlin Young from Oregon, where they were the leaders in creating one of these models at the Fabian School there in Portland, Oregon, where it was co-designed by parents. It was, they created the whole environment based upon what the community needed. That meant that there was a living room that was created because there was no community center for these parents to actually be able to connect to one another. That a wellness center was put there by Kaiser Permanente so that students could access the healthcare that they needed, not having parents have to make another trip. That there was access, a food store was put within the school so that individuals could have access to healthy foods, not just while they were in school, but foods that they could purchase with their benefits and take home with them, and there were supports for parents as well as the faculty around trauma support. Creating a healthy child necessitates that the adults around that child are healthy and supported. And so that's, really in keeping with the theme of community today. But all of the things that I described there didn't take a new piece of legislation. It was a creative use of Medicaid managed dollars, community benefit dollars from the healthcare system, and these private partners who came in and said, we see an opportunity to serve our community in a way that benefits all of us. So that's really when we talk about cross-sector collaboration and the creative use of appropriations that are already out there, whether that's CDBG or other funding opportunities, Medicaid, what have you. We have all the tools and resources. We have to come together to build stronger and resilient communities. So I want to thank you, Aza and Jesse, and Avina had to drop off a little earlier. We will record this. We are recording this webinar. So for those of you who were able to attend and want to share the news, the information with your friends, we'll have that posted on our website. But again, we will be back in 2 months. We'll be back in June for our next series. And that's looking at some of the policy as well as practice innovations in New York City to create a blueprint for healthy children. So thank you for joining the Center for Community Resilience. And for all of you, thank you for all you do to build a resilient nation.